Thank you very much, Dr. Abbas. At the outset, I would like to thank the organizers of Diabetes India 2015 for inviting me to participate in this very important workshop on diabetic food. In next 15 or 20 minutes, I'll be trying to discuss the mechanism or biomechanics of diabetic foot, special reference to diabetic neuropathy. As you will all see that we evolved over the millions of years from our ancestors apes. And for the first time, from quadruped, we became biped. And we assumed the erect posture, making us very superior in entire animal kingdom. But as far as diabetes is concerned, the disadvantage was the weight bearing of the body went to only 2 limbs, that is lower limbs, instead of 4. And due to this erect posture, our lower limbs required longer nerves to reach up to great toe than the upper limbs. And you all know that diabetic neuropathy invariably affects the longest nerves. And these are perhaps some reasons why lower limbs are only affected in diabetes and not the upper limbs as far as neuropathy is concerned. We have several functions carried by our feet. The most important is weight bearing while standing and walking, the maintenance of upright posture, locomotion, and various movements like running, twisting, acceleration, deacceleration. So these are all very complex choreographic movements that we perform with our feet. However, most of the time we always take them for granted and we miss them only when they are lost. It's very important to see that we have 2 phases in gait cycle. One is the stance phase and the swing phase. But when we are walking, you have to remember that only one foot is in contact with the ground. There is only a brief period where there is a double support. That means both the feet are in contact with the ground. Our 4 limbs move exactly in reciprocal relation. That means when the right arm moves, the left leg moves forward. Simultaneously, when the left arm moves, the right leg moves forward. During running, there is only brief period during the gait cycle when both feet are off the ground and are in the stance phase. So we can carry out several complex movements with our feet. However, in diabetes, it is the symmetric, diffuse, irreversible neuropathy that affects the feet, which is responsible for this foot condition. And we call it diabetic polyneuropathy, and it involves, as it is a polyneuropathy, it involves all the components of nerves, mainly sensory, motor, and autonomic. The motor neuropathy leads to various forefoot deformities, sensory neuropathy leading to lops or loss of protective sensations, and autonomic leading to dry skin and AV fistulae leading to prominent veins. Another thing that we have to remember in biomechanics, that we have several mechanisms working on the feet while we walk, stand, and do the weight bearing. One is the vertical pressure or thrust. When the foot strikes the floor, both the vertical pressure acts from above as well as from the floor. And smaller the surface area, more is the vertical pressure. This is very important. Smaller the surface area, it is inversely proportional to the vertical pressure. And then there is a horizontal movement of the skin while running, that's called as shear stress, And it has been seen that when a person walks for a while, the foot becomes inflamed and becomes hot. But in a normal person with normal sensations, he changes the posture and therefore no tissue damage occurs. But in diabetic neuropathy, when they exert a lot, there is inflammation and tissue breakdown. And that's how the story begins. And as you can see, this is the stance phase, and this is how our weight bearing is. We start with heel strike. This is the first area which bears the body weight. Then the lateral part of the foot, and most important is the forefoot, which during the takeoff phase bears all the body pressure. And therefore, you will always see that forefoot ulcers are the commonest in diabetic peripheral neuropathy. Another aspect of long-term hyperglycemia is glycosylation of proteins, and that leads to limited joint mobility or LJM. And you will always find that it is very difficult to flex the great toe. We call it hallux rigidus. And this type of rigid, this is a normal movement. The great toe must dorsiflex. But in patients with LJM have a rigid great toe, and that leads to further increase in plantar pressure. In our feet, there are two types of muscles. Extrinsic muscles, which originate in the leg and get inserted in the foot. Intrinsic muscles, which originate as well as insert inside the foot, like small muscles, intraossei and lumbricals. And in diabetic neuropathy, motor neuropathy leads to what we call as intrinsic minus feet because of the atrophy of the small muscles, and that leads to several deformities of the forefeet. You can see these are the classical deformities in the forefeet. One is the hammer toe, where there is an extension at the interphalangeal joint, and claw toes, where there is further flexion at interphalangeal joint, and there is extension at metatarsophalangeal joint. All our plantar tissue is well supported by fatty layer, and these fatty cushions are important because they are placed just below the heads of metatarsals. But when the claw deformities occur, the fat shock absorber moves forward, and this head of the metatarsal directly comes in contact with the skin and the ground, and that leads to early tissue damage and ulceration. So the cushioning that nature has provided is lost when there are such forefeet deformities. And you can see all these deformities both on the dorsum as well as on the tips of the toes and under the metatarsal heads. And when these deformed forefeet deformities are put into the shoes with narrow toe box or which are not wide enough, then there are further problems with pressure occurring on the dorsum as well as on the plantar side. And this is how you see the bunions occurring on the dorsum. You can see the deformities on the dorsum as well as on the tips of plantar aspects of the toes. And this is a normal weight-bearing foot. You can see a typical foot with a medial concavity. But in diabetic neuropathy with different structural damages, the overall weight-bearing area becomes small. And as I told you earlier, smaller the area, more is the vertical pressure. So a smaller area of the foot has to bear entire body weight. As the neuropathy progresses, you can see this is the entire weight-bearing area, and slowly with pes cavus developing, the weight-bearing area becomes small and more vertical pressure has to borne by the smaller weight-bearing area. And you can see the typical deformities leading to callus formations, ulceration on the tips, and there are some amputations as well. This is how the plantar ulcer develops. If we try to analyze, the first is because of the repeated stress and increased plantar pressure, there is a callus formation. And the next step is because of callus, the pressure under the skin increases by another 30%, and that leads to tissue damage, mostly hemorrhages in the subcutaneous area. And you can see once the hemorrhages occur, the tissue breaks down, leading to ulcer formation at the site of callus. And if the ulcer is not treated or is not closed in due course of time, that gets infected, and the infection goes directly to the bones, leading to osteomyelitis. These are the arches of the feet, medial and the lateral arches. And in Charcot foot, you can see a normal plantar medial arch, which is well preserved, and we call it concavity because of medial arch is never wet bearing. So this area is normally escapes the wet bearing. But in Charcot foot, it's the midfoot which gets damaged. Tarsometatarsal joints are damaged, and the medial arch collapses. And you can see very well that in comparison to normal concavity, there is a convexity, and we call it this deformity as medial convexity. And remember, 70% of all neuropathic ulcers occur on forefoot, either under the metatarsal heads, tips of toes, or bunions. But if you find an ulcer on the midfoot, you should be almost sure that you are dealing with a Charcot foot. And this is how the midfoot ulcer is seen, because the midfoot pressure increases because of the collapse of medial arch. And this is the final stage when extreme destruction occurs. There is a destruction of tarsal bones, as you can see here, tarsometatarsal bones, and severe osteomalacia in the metatarsals, and the entire foot becomes deformed. This is the involvement of ankle joint. This is normal position of normal foot, but when the ankle joint gets involved, it supinates, and this is, you can see here, when the involvement is of ankle joint, you can see the foot is supinates. And here also there is early involvement, so it's involving both the ankle joints. And this is the final stage of entire destruction of the ankle as well as the rear foot. So we have basically ischemia and neuropathy which are responsible for diabetic foot, but all these biomechanical factors mainly act through neuropathy. We have callus, numbness, deformities, ulcers, and eventually diabetic foot and gangrene. But for ulceration to occur, one has to remember it's not only sensory neuropathy, it's not only deformity, increased plantar pressure. All these factors have to work, and the activity level determines the ulceration. So we have to be very careful if we are dealing with patients with loss of sensations. A general prescription of go for a walk, brisk walk for 45 minutes is not advocated for patients who have loss of protective sensations. In fact, they should be advised that they should use feet to minimum and always take short steps. And as and when possible, avoid weight bearing or extreme walking, running, and other things. Feet can last for a lifetime, but in even diabetics, feet should last for a lifetime if we take due course of our feet and advocate our patients for proper foot care and foot education. Even in diabetics, feet should last for a lifetime. Thank you very much for the patience.